All right. Good morning, everyone. This is Tom Merrill with the Accountable Care Learning Collaborative. We are so glad to have you with us this morning for our webinar. It is a shorter one, so we're excited to bring you a high-powered session with David Muhlestein. The topic today is physician attrition, implications for future recruitment and training. Before we jump in, quick housekeeping. Join the webinar on your computer or phone so you can see the slides. David is going to be presenting some really great data. But if you are only able to connect by phone, don't worry, we'll send out the slide deck after the call with a recording. So questions, we usually will hold questions to the end, but for today, we're actually just going to take questions as we go. So use that Q&A module in Zoom. You could also email us if you want at members@accountablelc.org. And but the question module is best, and especially since if we don't get to them, we can follow up with you and even have a one-on-one after if needs be. So shoot us questions in the meantime, or we'll get to them after, and we'll just kind of go from there. So all right. So in the way of announcements, we have some upcoming member events to cover. So as you all know, work group meetings are on the third Tuesday of every month. This month they got bumped a week because of today's webinar. So we'll all be meeting next week, and we'll be excited to reconnect there. We have a couple of other webinars to announce today. One is very much related to the presence of David Muhlestein, and that is an introduction to Torch Insight. That's on June 6th. And a lot of the data that you'll be seeing today comes from Torch Insight. This is a data analytics platform that Leavitt Partners, the staffing organization of the ACLC, has built and is made available to, at least limited version is made available to ACLC members. So many of you are familiar with this platform, and we think it's a great resource. And we want to take a moment to introduce you to that resource if you're not familiar with it. So join us then. The next webinar is more of a topical webinar, and it's the status of Medicaid ACOs and their projected future. So that's just the next day on June 7th. So beginning of June, a little busy, and details will be forthcoming in the weekly news. So the final thing to cover before we jump in is the member meeting in DC. We have pinned down that date. Hopefully you're hearing it from your work group managers. That's October 23rd through the 24th. And it's looking like a really great agenda, and we would love to count on your presence. So block out that date. Okay, all right, well, let's go. Let me briefly introduce our today's presenter, who is someone many of you know. For the ACLC, David is a visiting fellow and helps direct some of the research that we do here and advises us on just how things are ran around here. But he's also the Chief Research Officer for Leavitt Partners, and he's actually based out of DC. David also serves as an adjunct assistant professor at the Dartmouth Institute and a visiting policy fellow at the Margolis Center for Health Policy at Duke. So David's pretty busy. We're excited to have him with us and to speak to us about physician attrition. So without further ado, I'm going to hand it over to David.
Thanks, Tom. And it's great to be with everybody today and to talk a little bit about some of the research that we've been doing. And the question that we have been grappling with is trying to understand how physicians are entering and leaving the practice of medicine. As you think about physicians, there's obviously a huge need to have a sufficient capacity to provide the needs of a population. And under an accountable care organization in particular, you need to actively manage and have touch points so that patients have access to appropriate care to prevent illness and to treat things at the lowest acuity setting. When you think of some of the major challenges with replacing physicians, it's the time and the cost and the training, all of these costs that really affect an organization. But from an ACO perspective, it's how do you maintain continuity over time? How do you make sure that there's some connection that continues with your patients so that they have an incentive to stay within your network, to stay within the organization, and really to be more effectively managed? There's also just an issue of maintaining and retaining attributed lives, and this comes from primarily on the Medicare side, where you're looking at the preponderance of primary care visits to attribute patients, and understanding how the retirement or patients or physicians that are leaving the practice of medicine might impact the number of lives that are attributed to the organization. And so what we've done for this study is spent some time looking at what the factors are that are associated with physicians that are leaving the practice of medicine, and then trying to tie that back to the data that we've collected around physician groups and around ACOs, so that we're able to kind of assess and say, how much of a problem is this, and what are the factors that are associated with people that are leaving the practice of medicine. So when you first start looking at physician practice, we'll start by defining what we're looking at, and we're including any physician who has submitted a claim to Medicare in the past 12 months. So this means we're focusing on Medicare physicians. So, for example, pediatricians that aren't working with Medicare might not fall into this. So we're just limiting it to the Medicare claims where we have good access to data. And also newly enrolled physicians. So those that first go in and start to enroll with Medicare in the PACO system in the first 6 months, they're being included as a physician that's in active practice. And so when we just look at the total numbers, you can see that we've had kind of consistent growth of the number of physicians over time that are working within Medicare. But you see that there's a lot of those that are both leaving and joining the practice of medicine. So actually from 2014 to 2015, there was a slight drop in the number of total physicians. But you see that there's a fairly large turnover rate. So we often think of the total number of physicians as being relatively consistent over time. But while there has been relatively consistent growth, there is a lot of churn within these as people are leaving the practice and other people are joining the practice of medicine. When we look at those that are joining the practice of medicine, so we looked at all of those that started in 2017 who had not practiced in 2016, and we saw that most of those joined that had graduated from medical school in the most recent decade. So that makes sense. Those people that had finished medical school and then had finished their residencies had started to join. You also, though, see that those that had graduated in the 2000s, there were still quite a few, and even those that had had not graduated for a long time, for 40 years or more, were newly joining this practice. And this can be a variety of factors. Sometimes it's somebody who has left the practice of medicine because they've had a purely administrative role, or maybe they've been working at an outside organization and doing non-clinical work, but then they've rejoined that practice of medicine. But when you look at those that are leaving the practice, so this is looking at people that practiced in 2016 but then stopped, you see that some of them were relatively new in their careers, 15 or fewer years from graduation. Others came from a variety of different time frames. And so when we think of physicians that are leaving the practice, it's not just the gray hairs in the bunch. It's not just people that are retiring from all work. They might be shifting roles. They might be moving to another opportunity. But there's a variety of different reasons that could have them. There's a subset of these that are no longer billing Medicare, and they've said, we're just not going to take those payments anymore, and we're just going to work on the commercial sector. That's by far a small subset of these physicians. There's a little bit of data issues with people that are no longer billing under their own NPI, which still happens, but is much less common because of how Medicare is set up. People really are expected and tend to bill under their correct NPI. But we're seeing a variety of physicians that are taking off time, potentially to raise a family for years, to work outside of medicine, or just work in a variety of non-clinical roles. And so a broad variety of reasons will affect who's leaving the practice of medicine. We looked at a number of factors just to identify what was predictive of people that are practicing medicine. So as we go through the list, this is the likeliness of them staying in practice. The most important factor was just age. The older the physician is, the less likely that they're going to practice the next year. So if you get to the ones that have graduated from medical school more than 40 years ago, there's a pretty high likelihood that they're not going to continue to practice the following year. It's just what happens when you get older. You're more likely to retire. But some of the factors that we found, so admitting patients to hospitals, physicians that are still doing this are more likely to continue in practice. We find that people that are actively practicing medicine will start to phase down in certain sense. They'll first change their practice where they're no longer taking call and admitting patients to the hospital, and then several years later, they'll ultimately retire. We found that males are more likely to stay in practice longer, and this is because many of the female physicians are the ones that are more likely to take time off to raise a family for a set amount of time. Living in a rural area also makes it less likely. We found that by and large, the rural practice of medicine has decreased over time. We know that there are significant shortage areas across the country in rural areas, and people are leaving the practice, either moving into some of them are moving toward urban areas, but many of them are just aging out and retiring, and they're not being replaced at the same level. And so communities that have been served for 20 or 30 years by a single physician or small practice are coming up where they have no active physician that's willing to come in and replace a retiring physician. Those that are in small group practices, we find, are more likely to stay in. This is the organizations where they are kind of running their own practice. So if you think of a onesie-twosie or small group practice where there's just the physicians are the business manager as well as the primary earner for that practice, they're more likely to stay in. There's a lot of invested resources and it's harder. And you're not going to leave a very small practice to go and become the medical director of that practice. It's just not an opportunity. But if you're in a larger practice, you might move or leave the active practice to go and provide another administrative role. And then we found that primary care physicians were also more likely to stay in. Now, all of this varies the relative significance of each of these different factors, and we have calculated those, but this is more just looking at the directional impact of these different factors. And so when we start to look at some of the results, we started to first just say, how do our physicians look differently? And not just physicians, but our general providers of care, people that are able to bill Medicare. And we sorted this by the average years since graduation. And so the average nurse practitioner finished their training, their formal training, their degree training less than 9 years ago. You look at those that are in general practice, and that's over 30 years. And so our cardiologists, for example, are relatively old. But there's a fair number of them that are out there, 20,000 that are still practicing. But you look at the median experience of 28 years, and the 75th percentile is 36, and the 25th is 17 years. You see that tends to be a much older population. Compare that to the emergency physicians, where the median experience is 17 years, and the 25th percentile is still 10 years of experience, relatively young in their career. And the average experience is 19 years for those. And so I actually flagged that because we'll come back to the emergency physicians in a little bit. But what you see here is that there's a wide variety of experience levels for the physician workforce that we have right now. And some of them just tend to be older, which means that, as that whole cohort tends to age, there's going to be more retirements and people that are leaving the practice going forward. There's also a big difference between the physicians and the non-physicians, so those nurse practitioners and physician assistants. What we looked at was trying to predict, excuse me, over a 4-year window, how many of those are likely to leave the active practice of medicine. And over a quarter of these non-physicians are predicted to leave the active practice, while just over 15% of the physicians are likely to leave that. And so much higher turnover for those non-physicians. Here we're looking at the total physicians on the left that are predicted to leave. And obviously, where there are more physicians to begin with, and this is not the non-physicians, this is just the physicians, they tend to follow the population centers. So California, Texas, Florida, New York, Illinois, the largest populations in the state also are going to have the largest total number of those that are predicted to leave practice. But when you look on the right, when we've looked at this model, you start to see that there's pretty significant differences. So you look at Nebraska, where it's just over 12% of the physicians that are expected to leave, and you compare that with California, where it's approaching 20%, where depending on where you are in the country, there could be more or less concern for this. So as you're creating strategic plans and trying to figure out how many potential departures you need to plan for, where you live really matters. And this reflects with the specialty distribution as well as the age of the physicians that are there and where they've been practicing. And so broad variety across the country. And so when you drill into these states at a more granular level, it even becomes, you even see differences at that level. So Northern California does not look exactly like Southern California. Texas or Dallas and Houston are different. And so understanding this is important. So as you're creating strategic plans around managing a population or around recruitment or around resources to invest in these additional capabilities to recruit and retain physicians, just knowing this is important as you create these strategies, and there's certainly a lot of variation. Here's where we did the predicted departure by specialty. So if you look at the emergency physicians, we saw that they were relatively young as it related to physicians, but by far they were the highest percent that was expected to leave, with over 40% of these leaving the active practice of medicine. And some of this makes sense. When you think about the emergency physicians, there's a high rate of burnout, and it's also shift work. So somebody goes in and works a shift, and it's relatively easy to say, I'm just not going to take shifts anymore, and you can see them transition. And so we see a large number of these previously practicing ER docs that are starting to move toward administrative roles, or they might go and work for an insurance company or a pharmaceutical company, where we see a large number of these that are starting to move. But when you look at some of the other specialties, so psychiatrists, which we know we already have a shortage of, they're already on the older side of physicians. If we expect that over a quarter of them could leave over the next 4 years, it could be a significant blow to access of care, and we've got to figure out how we're going to address that. When you look at some of these other specialties, going down to the other extreme with cardiac electrophysiologists, there is a very small number. One of it is because there's relatively few of these, and it's a relatively new specialty, so people haven't aged in that specialty over time. But it's a completely different reality for how these physicians are likely to leave the practice of medicine over time. When you start to put this down at the market level, you also can see differences where the emergency medicines are not all evenly distributed around the country, or who those are likely to practice. And so you can start looking at the practice level, start looking at the organization level, the market level, and understanding how these things play out. But I'd say the main takeaway here is that there's a large variety, and this is obviously not all the specialties. This was just kind of a distribution of specialties that I pulled out so that you could see kind of the range of where these providers were likely to fall. We also have now tied this to the group name. And what we did here is we looked at some large physician practices, so those that had 750 more physicians, and then we pulled out a distribution. Again, this is not comprehensive, but we said, where do different organizations fall? The real idea here is to, again, look at that distribution where you look at group health cooperative, where they could lose potentially a quarter of their physicians. That's what our model is predicting over the next 4 years. And then at the other extreme, the University of Pennsylvania Medical Group, which is just over 10%. And so who you are matters. And as you're creating strategic plans around your organization, or as you're starting to think about how you need to create recruitment strategies, knowing what the likelihood of the potential loss of providers over time certainly can matter, and certainly can influence strategic decisions as you're trying to create the right portfolio or the right team of physicians to provide all of the needs that are necessary for your population. Finally, what we also did was we worked with Care Journey to bring in some attribution data to identify the percent of the population of beneficiaries under the shared savings program that were likely to be attributed to a patient that was going to leave the practice of medicine. And so if you look on the left, what we did is we assessed at the state level and said, what percent of all of the MSSP beneficiaries are likely to have their attributed provider, their attributed doctor, leave that practice of medicine? And when you look at that, you realize that there's a huge variability. If you're in some of those Western states where you could lose nearly a quarter of your attributed lives just through the natural turnover of physicians that are leaving the practice of medicine, well, in other states, it's much lower. You know, at some point, you recognize that there's always going to be churn. There's going to be physicians that are leaving the practice of medicine or leaving an organization and going to another organization, and you just deal with that churn. But if there's significant levels of this, it can certainly affect how you can gain sufficient number of attributed lives for the size of the population to qualify for the shared savings program, but it can also significantly drive your churn. We know that there's a high amount of churn where beneficiaries are assigned 1 year and then they're not assigned to the ACO the next year, where you're trying to invest resources in preventive care or other disease management or care coordination services, but then the beneficiary is no longer attributed to you, and so it becomes a challenge. Part of this is just because of how the beneficiaries are moving around, but some of it is also from the physicians, those that are part of the ACO that are moving away or leaving the practice of medicine. And so it's something where the ACO has to plan for this, but is not necessarily well positioned always to prevent some of these things. But being aware of that can drive strategies and plans. On the right-hand side, we looked at the ACO level, where we looked at the total number of beneficiaries that were assigned and then the estimated % of them that would be lost just due to physician retirement or physicians leaving the active practice of medicine. And again, a wide variation, a wide variety of potential losses that are going. And this is, again, not a comprehensive number of ACOs or a comprehensive list of ACOs on the right, just a distribution that we selected. And so you see that it can significantly affect that. And so if you are Seton ACO, for example, up at the top, and you're going to lose a quarter of your beneficiaries, that could be 3,500 beneficiaries that could be lost over the next few years just from physicians that are leaving that practice of medicine. So obviously a lot of things that can drive decisions that you make as you are thinking about the strategies of retaining and attracting physicians. You know, this is primarily presented as an opportunity to show some of the work that we've been doing and start to raise questions that people might have. So one of the things that we're interested in is getting feedback from you is what questions should we be asking? I'll mention that this data is something that we make available through to our Gen site, but we also want to just talk about the overall conclusions and think about the implications of that from a strategy perspective, from an ACL perspective of how does this affect the competencies and how do we need to think of physician retention and losing people, and how does that drive how you manage populations. It also affects policy conversations of how we can create ACO type models, either at the federal level or even at the commercial level, that are effective and are going to reflect the reality that a variety of providers are leaving the practice of medicine. And so if you have questions now or in the future, we'd love to have a conversation and talk through those and understand what should we be looking at, what should we be investing resources to understand so that we can start to address them through the work that the ACLC is doing. And with that, we'll see if there's any questions, and if not, I'll turn it back to Tom to wrap up.
Okay. All right. So we don't have any questions in the queue, so if you're thinking about those questions, shoot them to me. So one question, actually, David, is how many of the providers that are leaving Medicare are still treating other patients? Realizing my mic is nowhere close to my face. Let me say that again. How many of the providers that are leaving Medicare are still treating other patients?
Yeah, so there is a trend that's going on where people are creating concierge practices where they say we're not going to take Medicare, or maybe they're not going to take any insurance, where they're just getting kind of an upfront fee and they're just seeing patients, you know, kind of a full service primary care office. And there's also people who say we're not going to accept Medicare payments, we're just going to go on the commercial route. And there are thousands of physicians that are making this determination, but when you look at it, the total number, it's definitely a minority of these. So concierge practices are growing, but they're still definitely a minority. Most people are operating through insurance, and they continue to do that. And most physicians recognize that it really doesn't make sense to practice medicine if you're not going to see Medicare patients, just because they represent such a high percentage of the population, and they tend to be those that are sicker. And so I don't have the exact numbers, but it was a minority of those that are leaving the practice, or those that are, or those who are leaving Medicare were continuing to practice medicine. Okay.
And a related question would be, I remember having this discussion years ago when CMS released their data on patient attrition and how high that number was. Actually, it was provider attrition and how high that number was. And the reason that it sort of became a discussion topic amongst our research team was how much that required CMS to redo sort of all of its numbers, because all the numbers flow from that. The benchmark calculation, the shared savings determination, it's all based on which patients are attributed to which ACO, which is directly tied to the physicians. This seems like it would be an important data point for folks like CMS to watch, because this largely will determine how much work they have on their hands.
I think it definitely affects CMS. I think it actually affects the ACO more, because the ACO is responsible to create their network of providers and make sure that they've got all of the tax identification numbers of all of the physicians that are participating and keeping that organized. And there's going to be it's a revolving door where you're going to have physicians that are leaving, that are no longer practicing, and those that are coming in. And so it's up to the ACO to really keep a track of that. From a CMS perspective, once you have those TINs, those tax identification numbers, you're able to go and run the numbers and kind of, run it through your computer algorithm. But from the ACO perspective, you've got to be on top of that. You've got to keep, be aware of where you're losing providers and what that impact is. One of the risks that ACOs have, and we've seen this in a couple of markets where you have an aging primary care workforce, where you start to lose some of these physicians to retirement, and all of a sudden you don't have sufficient attributed lives anymore. So even though you might have a pretty comprehensive network, the attributed portion that's coming from those physicians, you're at risk of losing those.
Yeah. Okay, well, some very important things to watch, David. We're really glad that you were able to join us today. And for those of you who have questions that are just now coming to you, shoot those to us via email, and we can have offline conversations. So as we wrap up, a reminder, we have work group meetings next Tuesday for this month, but they are generally on the third Tuesday of the month. So if those aren't on your calendar, let us know. You can email Jacqueline, myself, or our general members at accountable.lc.org, and we will get you added to those. And then be sure to block out the dates for June 6th webinar, so you can get introduced to the full spectrum of work that in which David Muhlestein is engaged on the Torch Insight side of things, and then Medicaid ACOs and their projected future on the 7th. And then we'll keep beating the drum, the 23rd and the 24th of October in DC. We would love to see you in person, so block out that date. All right, thank you guys so much. And for any of you who just have general questions about the ACLC, there's that email I mentioned earlier. So thank you for joining, and we will catch you next time. Bye, everybody.